Hello and welcome to the Genetics Podcast. I'm your host, Patrick Short. My background is in population genomics and studying the genetic causes of rare disease. I did my PhD at the Sanger Institute in the University of Cambridge and have been in biotech since 2018 when I started Sano Genetics. Sano Genetics helps academic and industry researchers to run large-scale genetic testing programs that speed up their clinical trials, generate data sets for the next big breakthrough, and give participants the best possible experience taking part in research. Each episode of the Genetics Podcast, we bring you insights from the leading minds in genetics and precision medicine, including household names and Nobel Prize winners, as well as early career scientists and biotechs working on the next big breakthrough. Whether you are a scientist, entrepreneur, executive, patient advocate, or simply someone curious about how genetics shapes our world, you're in the right place. Thank you for listening, and let's get started. Welcome, everyone, to the Genetics Podcast. I'm really excited to be here today with Dr. Tim Jobson, who's Medical Director of Predictive Health Intelligence and a consultant physician at Somerset NHS Foundation Trust here in the UK. I've had the fortune of collaborating with Tim on a really cool project that we're going to talk about a little bit towards the end of the program here, but more generally, we're going to start with liver disease as a whole, where the challenges are, where the opportunities are. Tim has been working in this space for a really long time and actually opened my eyes to some of the incredible stats in a not so good way, some of the infamous stats in the field right now, how challenging these diseases are to detect early, prevent. We are making progress, but there's still a lot of work to be done. So if you're interested in metabolic disease as a whole, this is going to be a really cool episode. Tim, thank you so much for taking the time to join me.
Well, thank you very much for having me on the podcast, Patrick.
I alluded to some of these very challenging statistics about metabolic liver disease. Can you talk a little bit from your perspective as both an entrepreneur and a clinician of what you're seeing and what the statistics are relative to other conditions like neurology or cardiovascular disease that harm a lot of people, but we've made probably comparatively much more progress in the last few decades?
Yeah, so probably the most impactful figure is mortality rates from liver disease itself. And if you look back over the last, we're talking 50 years now, mortality rates in the UK from liver disease have gone up fourfold. So for every 100 people in 1970 who died, 400 will die now. And if you compare that to the progress made in cardiovascular disease, in cancers, in renal disease, many other conditions where there's been a general improvement in outcomes, mortality, survival from diseases and so on, we are not winning with liver disease. That's the first thing to say. The second thing to say is it's not all alcohol. So the first thing people will think about when we talk about liver disease is, well, if people didn't drink as much, then they wouldn't get alcohol-related liver disease. And that is true. We know there's interventions at population level that can really help improve those outcomes. But the big change and the big shift is in metabolic liver disease. So what used to be called fatty liver is now called MASLD, which is a bit of a mouthful. It stands for metabolic dysfunction associated steatotic liver disease. Why was the name change just came in about 18 months ago? Why was that? Because we didn't want fatty, we didn't want alcoholic, and we didn't want non-alcoholic as words that people were using, a lot of stigma associated with. So metabolic dysfunction, the metabolic syndrome, is growing. And it's a driver of other diseases, of hypertension, diabetes, poor lipid control, poor cardiovascular outcomes, and malignancy. But the liver is the metabolic engine of the body. So that's where it all starts. And that is the disease that's coming. So fat storage in the liver, leading to inflammation, leading to scarring, and poor outcomes from liver disease. That is the huge change. And if you go at the population level, then you're starting to see 1 in 3 of the adult population with excess fat in the liver, for example. And in some populations, it's even higher than that. There's some populations where it's up to 70%. Oh. And so we know this is a big and growing problem, and there's a long time lag from when you first start storing fat in your liver, perhaps in as early as your teens or 20s and so on, until the poor outcomes arrive. So that's a big issue.
Yeah. And you were seeing this, I suppose, in your clinic in Somerset, but you started a a program, Somerset Liver Improvement Program. Can you talk a little bit about the origins of that and what you've done through that program within and tell people about Somerset a little bit? A couple million people, so it's a big population that you can actually have an impact on, right?
So it's 600,000 population covered by one large and one slightly smaller district hospital and a relatively small hepatology team. So what drove this project was late diagnosis, and late diagnosis underpins chronic liver disease, long-term liver disease. That is the big thing at the moment everybody's thinking about, and how do we address late diagnosis? And what do we mean by that? So whatever the cause of your liver problem is, whether it's excess fat storage, whether it's alcohol, or whether it's autoimmune or metabolic or genetic diseases, whatever is driving it, it's so often a silent disease. It's progressive, it's silent, and people don't present with symptoms until it is far too advanced for meaningful treatments. So that is the issue. So how does that manifest itself in clinical practice is an urgent email, an urgent referral from a GP saying, I've got a patient, they've got an enlarged liver, I've scanned it, there seems to be a mass there, because one of the consequences of all this scarring is primary liver cancer, which is often an end stage of these diseases. So the first time the patient knows they've got a liver problem,
they've got liver cancer.
When they've got liver cancer from that liver problem and they have a terminal disease.
Wow.
Or a disease that requires a lot of good luck and a lot of very invasive treatments up to and including transplantation to try and cure it. So late diagnosis is almost a norm in liver disease. And that has been happening for many years, and we've all been doing this in clinic. And it came to a point where I'm thinking, kind of enough is enough. I've seen one too many patients like this, a patient my age presenting like that, no symptoms, no risk factors, not a drinker, not using intravenous drugs as a risk factor, all these things. And yet here they are presented with late disease. And there's an issue that we all knew, is that all these patients have a signal in their prior blood tests, a subtle signal of minor abnormalities, which are lost in the overall noise of blood tests being done. So we looked at the numbers, and roughly for Somerset, we would be saying that 25,000 GP liver tests are done every month across Somerset. That's a huge number. And say 3,000 of those are abnormal. So 60, 70 practices across Somerset, GPs are seeing dozens of abnormal, minor abnormalities in the liver tests appearing on their desks day in, day out. And somewhere in the noise, there's a signal of the one person that needs picking out and looking at. So by the time they come to us, I do liver disease day in, day out. I recognize the signals, the patterns that we're looking for. But actually getting the whole liver world, the whole community that stretches out into primary care to recognize that is very difficult. But we know what the patterns are. And so what we did in the Somerset Liver Improvement Program was, well, we just brought all those liver tests into one place and analysed them using modern technology, using a computer rather than waiting for people to scan through blood tests. We can find these patterns. And that's what we did. So in a nutshell, we got a grant awarded back in 2020, started working through lockdown on a computer program. There are a lot of issues around the governance of this. Is this the right thing to do with people's historic blood tests? It's private clinical data. So there's a number of processes, but our greatest ally in terms of getting that through, getting the acceptance we're going to do this work, was the public and patient groups that we set up. And the public view was very much, what do you mean you're not doing this already? Of course you should. Of course you should check. Like, if I have somebody sticking a needle in my arm and there's something wrong, but it's not kind of being picked up, want you to check in.
Please send me a letter.
Please send me a letter and do it. And we got to that stage. So we got to that stage where we're actually sending the letters out. So in the Somerset program, writing to patients, you need a review of your liver health, or we'd advise a review of your liver health. It arrives out of the blue. We've interviewed people. What's it feel like to get that letter? What's it feel like to come to clinic? We've got some great patient experience data. So that was the process that we put in place. And fundamentally it works. And so that's the Somerset Liver Improvement Program, sort of end to end. That's 6 years of work, just in 6 minutes.
In 6 minutes. And I mentioned the work we're doing together, and in many ways, it's adding a new technology on top of the bedrock of work you've already done, which is genetics. And we can talk in detail about the role that genetics might play, what we know about it today. It's definitely not routine, and so it may be in the future, but I want to understand which areas of liver disease it's becoming more routine, because you talked a lot about MASLD and MASH, but we've also have PBC and alpha-1 antitrypsin and other conditions. Could you talk a little bit about where we're routinely using genetics today, or at least more routinely than in the past? And then where are the big gaps still that you see today?
Yeah, definitely. So the sort of paradigm of this is a condition called hemochromatosis. So this is primary iron overload, where the body's the protein that helps sense how much iron you've got on board and tells your gut to stop absorbing iron starts to it malfunctions if you've got a mutation. So if you're homozygote for those mutations, that off switch for absorbing iron doesn't work and you absorb lots of iron. So the hemochromatosis is that condition. It's an extremely common condition. So homozygous rates in the sort of population we're looking at, depending on how you look at it, 1 in 200 to 1 in 400 homozygous rates. So that is, it's a common disease. There's incomplete penetrance, but even with incomplete penetrance of this into the clinical disease, we're still missing an awful lot as well. So it's out there and we're not finding it. But when we see somebody with iron overload, we can test for the common genetic mutations, which cover 99% of the cases out there, and identify those patients. And that firms up the diagnosis, but also gives us opportunities for screening family members and so on. So that is where it's routine in clinical practice. We reach a threshold on blood tests, we do the genetic tests, we treat the disease. Where it's coming also, I think the alpha-1 antitrypsin story is really interesting because the homozygote rate for that is relatively low. This also, we know it's not picked up very frequently because the tests aren't done. The test is usually done for the phenotype that implies the genotype rather than the other way around, but the principle's the same. And we know from our data in Somerset, we probably know about only 1 in every 20 homozygotes out there. But we do know a lot about the heterozygotes, and we know the heterozygotes it acts as a cofactor for other liver diseases. Now, that hasn't really quite entered routine practice, how we use that information, but there's emerging evidence that this is really important when you are a patient in front of you and you want to know, firstly, how much liver damage has that patient had already? That's the kind of fibrosis assessment that we do routinely. And the second question is, what's the trajectory of this? Is this going to carry on getting worse, or is this something with some relatively simple interventions? And so information like the alpha-1 antitrypsin phenotype and genotype is going to help us. And that's coming in. There's a whole lot of other areas where we're only just scratching the surface, where it's not entered routine practice. So MASLD, there are clear genetic signals for worsening disease. But at the moment, this is really research. There are starting to be some early pharmacological assets coming through, which may work in specific genotypes of the disease. And so precision medicine is coming, but I think it's still a few years off. So there's a whole spectrum. And I think probably I don't really think about the genetic component of liver disease that 5-10 years ago. We weren't thinking that, even though we were doing it routinely for hemochromatosis, that was kind of the exception. Now I think we're starting to think, actually, this is going to start to play out at ours. Other areas where we know it's important from the autoimmune diseases and so on, there are clearly some inheritable characteristics that part of it is polygenic, it's complex, and doesn't necessarily tell you how to treat people differently. So that's coming.
I want to have your perspective on the current state of the art of, and I probably need to break this problem down in a couple different quadrants, but let's say you have a patient that you've managed to detect relatively early. What can you do today to understand how quickly or slowly they're going to progress? What are the state of the art tools you have that patient in your office that doesn't have cirrhosis or liver cancer yet, but you want to understand how, to your point earlier, how urgent is this problem? And then possibly related to that is just the population level screening. You maybe don't know anything or very much about someone, and you just want to use the existing data to understand who should we get in for a closer examination. How do you think about, are those two problems related? Which one are we further along, and how do you think about the different tools to use in each of those cases?
So yeah, there's two components. There's stage of the disease. So how progressed is this chronic condition at the point you see them? And I think across hepatology, we've got a modest way down that pathway. So starting to understand, and it's really how much fibrosis or how much scarring, has established. Is this established cirrhosis that's advanced scarring that we call F4 disease, or is this earlier in that process? The second question, trajectory, we have very little that helps us right now. So that's really key. So all these conditions have interventions that can help. If you can persuade a patient to drink less alcohol or drink no alcohol, their disease will not only progress slower, but it might even regress. If you treat their hepatitis C or their autoimmune disease, you can get disease regression. So we know that even from advanced scarring, there's more regression than we ever thought there was. Now we've got great treatments. If you treat underlying metabolic syndrome, you can get regression of scarring. So the Essence study, major study published 18 months ago, showing in the US, showing that semaglutide treatment for diabetes and weight management actually cause regression of fibrosis. So that trajectory is not only not well known, but it's also very influenceable by getting people on the right treatment. That's dodging the question, because we really don't have anything that says, well, how is this patient going to progress? Then it comes back to standard clinical practice. It's follow-up in clinic. I will see you in a year's time, in 2 years' time. I remember these are slow burn disease. These are diseases that progress over decades, not a short time scale in most cases. But seeing somebody in a couple of years' time, you can repeat the test and say, actually, your fibrosis is getting worse at a rate that makes me really uncomfortable. We're going to have to do more to try and get you back on track. But it's that interval measurement that's out there. The other question was really about how do we
population scale screening?
What do we do at a population level? So, and that's where our project came in to being, but also it's kind of the natural step. So we've got patients that we can identify using existing blood tests. We call this the solution that we did. I called it hepatocyte. They can delve into a huge number of blood tests. We can pull out patterns very quickly, and we can invite people for care. But that's still case finding at an individual level. What we want to do is say, what are the signals in the general population? And that will show us who's got an emerging problem. And that's coming. And that needs to be a combination of what signals we picked up, maybe on routine testing. So the data are out there. It's in the primary care record. It's in the secondary care record. It's in the lab systems. It's there. And we can do that. And that's where the genetics come in. So if we find somebody who's 30, who's got a signal that they've got the condition, but it hasn't progressed much, that's when I'd really like to know, is that somebody who's got early disease, who under normal circumstances, I would say, to the primary care practitioner, don't refer at this stage, just keep monitoring, because that's all we've got. And is somebody we want to intervene with now and get on treatment or not? And so that's the hypothesis, but yeah, we need to start testing. We have started to test as part of the LiveWell study. Are there ways of identifying people, combining those two different signals?
Can you talk a little bit about? Yeah, go ahead.
I was just going to say, because screening, so this is my view, people talk about screening for liver disease, but it's the only condition where they sort of talk about screening without a diagnosis. So when we're screening for bowel cancer, we're screening for a specific condition. When we're screening for breast cancer or coronary artery disease, we're screening for a very specific condition. But we're screening for liver disease, we're not really screening for liver disease. Isn't the thing. It's multiple different diagnoses. So what we want to do is risk stratification for a liver problem. We can unpick the exact disease later on. And so inevitably what you're not doing is you're not actually looking for a diagnostic test with a certain degree of sensitivity, specificity, and accuracy at a population level. What you're looking for is a way of risk stratifying the population and understanding who needs that next step, who needs to come into a neighborhood fibroscanning clinic or a secondary care autoimmune disease clinic or whatever it is. That's the subtle difference, but I think it's really important. And so why the approach is always going to be somewhat different. And genuinely, it's about trajectories over time, spotting this, who's getting worse and who's not getting worse.
Yeah, we talked about the LiveWell program that we've been working on together. Just to describe it briefly, so you used hepatocyte, which is the algorithm that you all have developed and the tool that allows you to use the existing data to pick out potentially at-risk people. We invited both at-risk and not at-risk individuals across the Somerset Foundation. They were then invited to take part in genetic testing and also non-invasive fibroscanning, and we had really high uptake. I think more than 99% of people wanted to take part in the genetics, which I thought was really interesting because you do get questions about how interested or accepting are people of genetic testing, and I think this gives us a really useful data point, at least in this context and in this condition. We've literally just closed recruitment, so we don't have results for it quite yet. But I want to get your sense of what you think. What are you expecting to see when you start to add on imaging and genetics and other data types on top of the routine testing? How is it going to help to answer this progression question? Under what circumstances? And also talk about trials a little bit, because trials have historically used liver biopsies, but are starting to shift into using the non-invasive liver ultrasound as an endpoint, right? Or will be doing so soon. So I'd love if you could talk a little bit about how do you actually run trials in this kind of population where you start to layer on all these different data types?
Yeah, so at the beginning, I think we all thought this was quite an ambitious study to do because it was doing something a little bit different. We wanted to reach out to the whole population. And so we're not just asking people to come to clinic, would you like to go into a study or not? Because we know that's an extremely slow way of recruiting patients or writing out to existing known patients with specific conditions. So that's the first step, doing it in a hepatocyte and saying, we think you might have a signal that also means you're eligible for a study, but you may be a control and you may be a case we're not telling you at this stage. So that was completely untested in this context. I don't think anyone's ever tried this for a liver cohort of patients. And the uptake was much better than I thought. That was the first thing. So the second thing is, it kind of feels a bit complicated. We're going to do this genetic panel, so we need to give you participants enough information about what we're doing without totally overwhelming them with science and genetics and so on. And then and still engage them in this process. And we need a physical process that works. So home testing worked. It was a very good way of doing this. So producing a saliva sample and sending it back for genetic analysis made it very easy for patients to do, and I think contributed to making this a more accessible study for everybody. I also think that tells us something about how we can do this in clinical practice in the future. This is potentially a method that we can get patients tested for the genotype that we're looking for much more easily. We can do it in the clinic, we can do it at home. Yes, it's a great way of doing it. So that was really, really interesting. Where does this go in terms of other trials? So ours was a diagnostic study, the endpoint being having measurement of liver stiffness and ultrasound measurement of liver stiffness and fat storage. But that endpoint could be different. It could be an MRI scan, but it also could be, okay, now you're eligible to enter into a drug study. So we can do exactly the same that we did with this study as a funnel, as a way of recruiting patients with the right risk factors, the right trajectory, the right genotype, whatever it is we're looking for, and then ask them if they would like to enroll in a study. Because for a lot of drug studies, we spend an awful lot of time filtering out the people who are not eligible. If we identify the whole population, we've got a much bigger pool of patients, and we have a much better chance of getting the right patients through that first level of screening, and be able to push recruitment much further. So that's the ambition. That's where we're going with this, and we're already discussing with sponsors about how to put this into practice. There are some slightly different regulatory issues that need to be overcome, but those barriers were not insurmountable at all when it came to LiveWell study. And I think one of the great things in its favor is that it's opening up the opportunity to be part of a clinical study for many patients who don't get that access normally, particularly from deprived areas and so on. So that's really good. And the process felt much more manageable than some of the other studies where we're always just kind of rummaging around, if you like, for patients almost. We're waiting for the patient to appear in clinic. We have no planning. We have no control over that process. We might have a database, but the database is out of date and we can't query it very well. All these sort of things really are barriers to recruitment. Having a much more systematic way of finding the right patients, I think is really exciting. And of course, as our footprint expands, because we're rolling out Pulsite to a range of different hospitals across the Southwest now, who are taking up this tool for their own work, their own clinical work, for their own studies, this is going to become really powerful.
What do you think about expanding this paradigm to other therapy areas? Obviously, you're a liver specialist, and your expertise is in many ways baked into the tool. But how do you think about applying the same paradigm in other areas of cardiovascular disease or neurology, dementia? Do you think that this field is at a particular time and place right now where it makes sense, specifically in liver disease, or is this something that people could think about more broadly?
So it definitely gets outside of liver disease, and we're looking at that, and we have a couple of proposals being worked on for research at the moment. So looking at that long-term signal in people's blood tests, there's that fingerprint that's left behind in prior blood tests that implies, okay, you might have a bit of a liver problem, but actually you've got quite a heart problem coming your way.
Yeah.
So can we do that? I think almost certainly. All of the modern medicine risk scoring, the risk algorithms, it's all about a single point in time. So what is your FIB4 score today in liver disease? What's your Q risk score today in terms of cardiac prevention and so on? It's all about where you are today. And yet that's not what's going on in the body. What's happened is some damage has accumulated in your liver with scarring. So the damage has been accumulating over time in your coronary arteries. And now you have significant damage and calcification and so on. So it's the same story for all these chronic liver diseases. The second thing is there's probably some very common themes underlying all these things. So the metabolic syndrome drives not just liver disease, which is my interest, but of course it drives cardiac disease. It drives diabetes. The downstream consequence of that, like renal disease, strokes, 20 major malignancies have metabolic dysfunction as an underlying risk factor as well. So wherever you go in medicine, the metabolic dysfunction crops up, and we know it's driving a lot of different diseases. We know it's a long-term condition. And it leaves that message behind in the blood tests that we can find. So we're working through that. I think there's some areas where it's going to be pretty quick. We've looked at lipids, lipid management and diabetes. We can quickly spot the people who need more attention. That's really easy to do with, and it's the same patients probably who need some attention for their fatty liver as well, but we can find those patients. I don't think you even need more research in that area. It's just a number crunching exercise that we need to translate into better population health management.
Yep.
More research is going to tell us about cardiac risk, and I think some really exciting opportunities around cancer risk as well.
Oh, interesting. Yeah. How would you approach cancer risk?
So there are changes in blood tests that predate non-specific symptoms, and the non-specific symptoms then predate the actual overt symptoms. So by the time you've got overt symptoms in many malignancies, that's because there's something quite major going on. But the growth of cancer is impinging on other organs or other structures and so on. That's when the symptoms arise. And of course, it's all getting a bit late, because when it's invading elsewhere, you've got a problem. So that's a kind of more very general overview of it. And we know that there are changes, subtle changes in the 3, 6 months, maybe even 12 months ahead of time that a problem is coming. And those are the patients that they've had those changes might be picked up, but they also then go with non-specific symptoms. So lots of people attend their GP for non-specific symptoms and have some normal panels of blood tests done. And again, there's nothing dramatic on there. They're often subtle signals. So we can compare current with past for that patient and say, actually, this patient's bloods are changing. Something is evolving. That is early days. There's a number of people looking at that. I think what we've done is, through the parasite work and LiveWell work and so on, we're showing how to practically very quickly put these sort of things into place. So we should be able to very quickly start to roll out technologies and new science when the science is ready.
Yeah. What I've always loved about what you all do is using the existing data. It's so important, and like in retrospect it's obvious, but we get really excited about let's apply this new thing. But it is so much easier to adopt a change in a system if you're just saying, look, we're going to look at what you already have and we're going to immediately find cases that are missed or need extra attention, and then you can start to layer the new technologies on top of that. But the making use of the existing data, I think, is a really amazing unlock here, especially in the NHS, where I think it has the potential to be the best health system in the world for research, and it already is on many measures of patient care. So it's exciting to just see how you're building on top of that really strong foundation already.
Yeah, and the impact can be at an individual patient level as well as the population level.
Yeah.
So I saw a patient in the early stage, the pilot, who we then had subsequent follow-up to see actually that the treatments had been successful. So 2 underlying liver diseases, neither of which known, both of which treated successfully, regression of fibrosis. So you can do an actuarial calculation to life years gain for an individual patient.
Yeah.
And we're talking 10 to 15 life years gain for an individual, and quality life years. So this is a big increment with a small number of patients. We can aim in a small number of patients, or we can just look very broadly and say this whole group of patients that we've identified, all of them need some interventions to improve metabolic health or whatever it is. And the therapeutic landscape is evolving rapidly, and we need to keep up with knowing exactly where to target new therapies. Otherwise, there's going to be a wash with new therapies that nobody really using effectively. Nobody's targeting them. That then becomes A, ineffective, and B, very expensive very quickly.
Yes.
So using new therapies in exactly the right groups, I think, is critical.
So what does the next chapter for you look like here? What are you focused on for the next couple of years as we close out?
So probably I'm fascinated with what is outside the liver. I am a liver doctor, so I think some of those things are going to be really interesting, though, to see, can I persuade my colleagues to, around the corner in the cardiology department, literally 10 yards from where I'm sitting right now. And they're going, actually, yeah, we think that, let's have a look at how this works. So that's great. So that's kind of exciting. I think we want to expand our footprint. So I simply want to see the numbers going through. I just get this feeling. So there are patients that I know we've got too late, and they're kind of burned into your memory. I just want, those people are out there right now, and we need to be finding them, and we need to be doing something, and that needs to be a health system approach. So that is really critical. And then the precision medicine bit of this is fascinating. Where is this going to take us? Where are we going to get into much more of that? And I think if we can knock down some of the barriers, so there's the economic barrier. No, genetic testing is not expensive anymore. It used to be, but it really is accessible. We can make it accessible. We can make it acceptable. We can get over all the hurdles that, around genetic counseling, which are really important. We need to empower clinicians to do more routine genetic counseling and leave the more complex stuff to the people who are properly trained in it and so on. As we can start to knock down those barriers, it's going to become a thing. And I think that's going to come together nicely with therapeutics. So precision therapeutics are going to be coming out at about the time we're going to be doing precision diagnosis. And then the outcomes will be better, and the treatment will be more cost effective. So that's kind of where it's going. And I want as many people as possible not to end up having to have a transplant, not to have advanced disease and not to be on the ward, because the sharp end of liver disease is the patients that I've been seeing this morning on the ward round. And there's not a huge amount that we can do to make these people better. Some do get better, but it's advanced end stage disease is so often avoidable.
Yeah, absolutely. Well, Tim, yeah, thank you. This has been an amazing conversation. Thanks for all the great work that you do.
Thank you.
Thanks, everybody, as always, for listening, and we'll see you next time. Thanks, as always, for tuning into the Genetics Podcast. If you enjoyed today's conversation, the best way you can support the show is by sharing it with a friend or colleague who might find it interesting as well. We'd also really appreciate if you could subscribe, rate, and review us on Apple Podcasts, Spotify, or wherever you listen to podcasts. This helps other people discover the show when they're searching for content on genetics, precision medicine, or biotech. We always want to hear from you as well. If you have feedback or questions or want to be featured on the show, you can email us at podcast@sanogenetics.com. You can find me on LinkedIn, Patrick Short. You can find us as well, Sano Genetics, on LinkedIn, or reach out on Instagram at The Genetics Podcast. And finally, a special thank you to the team behind the show who makes this possible. Joy Ismail produces and manages the show. Jane Reddy Webster keeps us organized, and James Pierce from Selective Frequencies for his expert audio engineering. I'm Patrick Short, your host. Thanks again for listening, and we'll see you next time on the Genetics Podcast.